Core Memories, the Physio Matters podcast, session 10. Original publication date, the 28th of September 2014, with Anne Gates. This feature is sponsored by Rehab My Patient. You can get 3 months free trial of Rehab My Patient. Just go to rehabmypatient.com/Physio Matters. By the way, it is the best exercise prescription tool. I've tried quite a few of them. It's brilliant. In 2014, clinical pharmacist and exercise medicine champion Anne Gates spoke to Jack Chew on the Physio Matters podcast about the need to reposition physical activity at the centre of healthcare. She described physical inactivity as a public health crisis, advocated for integrating exercise into every patient consultation, and encouraged us to view exercise as a therapeutic agent as legitimate as drugs or surgery. Nearly 12 years later, the evidence base for exercise medicine has grown substantially, and many health systems are increasingly prioritising physical activity in policy and clinical practice. In our first Core Memories feature, we assess how Anne's insights align with current evidence and thinking in 2026, exploring whether her 2014 perspectives have been supported, updated, or reframed by the research. Exercise as medicine, then and now. 2014. Anne framed exercise as being akin to a pharmacological intervention, something that should be prescribed, monitored, and integrated into treatment regimens. She argued that exercise has cost effectiveness comparable to many drugs and called for healthcare systems to see exercise as an equal partner to traditional medicine. 2026. Anne's viewpoint has only strengthened with advancing research. Over the past decade, multiple large-scale meta-analyses and clinical guidelines have solidified what earlier researchers hinted at. Exercise has measurable effects on morbidity and mortality across a range of chronic conditions. For example, cardiometabolic disease. In secondary prevention and some high-risk groups, structured exercise interventions can achieve mortality outcomes comparable to drug therapy in the evidence base. And exercise-based programs, e.g. cardiac rehabilitation, reduce cardiovascular mortality and recurrent events, though effects on all-cause mortality are more variable in contemporary trials. Type 2 diabetes. For type 2 diabetes, physical activity is firmly positioned as a foundational component of management rather than optional advice. Contemporary NICE and American Diabetes Association guidance places structured exercise alongside pharmacotherapy from diagnosis, recognizing its role in improving insulin sensitivity, lowering HbA1c, a blood test that measures blood glucose levels over the past 3 months, and reducing cardiovascular risk. Meta-analyses consistently show that aerobic resistance and combined training meaningfully reduce glycemic markers, with combined approaches often producing the greatest benefit. While exercise does not replace medication for most patients, it can reduce medication burden in some cases and remains one of the most powerful long-term cardiometabolic interventions available. Cancer survivorship. Exercise is now embedded within survivorship care in many oncology pathways, with international guidelines recommending structured aerobic and resistance training following treatment. Level 1 evidence, including large randomized trials such as the Challenge study in colon cancer survivors, demonstrates reduced recurrence risk alongside improvements in quality of life and physical function. Across tumor types, systematic reviews consistently confirm exercise as a safe, effective adjunct in post-treatment care. Health organisations and clinical initiatives, e.g. Exercises Medicine /ACSM and NHS England aligned programmes, increasingly treat physical activity as a vital sign assessed in routine consultations and linked to actionable goals. Anne's view that exercise should be monitored like a drug has gained traction in clinical pathways and electronic medical records, where best practice is for physical activity metrics to be charted alongside markers such as blood pressure and blood glucose, although adoption remains variable. Conclusion. The brief premise of exercise medicine articulated in 2013 has been reinforced and operationalised in 2026. It is not just progressive advocacy, but a mainstream clinical priority in many healthcare systems. Brief interventions and making every contact count. 2014, Anne emphasised brief teachable moments within consultations, short but confident advice linking exercise to measurable health outcomes. She cautioned against treating exercise advice as a quick fix and advocated for monitoring and follow-up analogous to pharmacotherapy. 2016. This approach aligns closely with contemporary behavioural science and implementation research. Brief physical activity interventions delivered in primary care have demonstrated modest but clinically meaningful increases in activity levels, particularly when combined with goal setting and follow-up support. Even very short conversations, often under 2 minutes, can prompt behaviour change when paired with structured referral pathways or digital reinforcement. Making every contact count remains a valid and widely endorsed model within UK public health strategy, though modern implementation increasingly incorporates digital systems, including patient portals, remote monitoring, wearable data integration, and automated messaging, to improve adherence and clinician follow-through. Importantly, systematic reviews confirm a point anticipated. Brief advice alone is usually insufficient unless embedded within wider behaviour change systems that include ongoing support, environmental accessibility, and tailored feedback. Current nuance. Recent work in behavioural medicine emphasises contextual tailoring. Interventions are most effective when adapted to readiness to change, health literacy, socio-economic context, and cultural background. Conclusion. Anne's 2014 framing of brief, confident, monitored interventions anticipated current best practice. In 2026, the principle remains sound, but effectiveness increasingly depends on structured follow-up and digitally enabled support systems. Healthcare systems, barriers, and equity. 2014, Anne argued that healthcare systems were poorly designed to promote exercise, stressing the need for community links, clinician empowerment, and breaking down barriers that prevent physical activity. 2026, subsequent policy frameworks increasingly reflect this thinking. The last 5 years have seen inclusion of physical activity targets within national strategies, including NHS long-term plan delivery updates and the UK Chief Medical Officer's physical activity framework, which position prevention and activity promotion as core system priorities. Growth of community-linked referral schemes, including social prescribing pathways and exercise referral programs designed to connect patients with local activity providers through primary care networks. Greater integration of social determinants of health into physical activity policy, with recognition that access to safe environments, green space, transport infrastructure, and socio-economic stability significantly influence participation. However, implementation remains uneven. Despite national ambition, regional variation in service availability and infrastructure persists, and disparities in access to community programs continue to reflect the postcode lottery. And described. A notable evolution over the past decade has been a sharper focus on health equity. Research consistently demonstrates that disparities in physical activity participation by ethnicity, gender, age, disability, and deprivation. In response, targeted programs, particularly those addressing adolescent girls, older adults, and underserved communities, have demonstrated improved engagement and adherence when culturally and contextually tailored. Conclusion. Anne's 2014 critique of structural barriers remains valid. By 2026, however, policy frameworks are more explicitly equity-oriented and data-driven, even if delivery across systems remains inconsistent. Research gaps and implementation science. 2014, Anne challenged researchers to produce rigorous trials comparing exercise interventions with other treatments and highlighted deficits in long-term follow-up. 2026. Over the past decade, research quality in exercise medicine has improved substantially. Large pragmatic trials now commonly incorporate structured, standardized exercise protocols aligned with public health guidance, including aerobic volumes consistent with 150 plus minutes per week and inclusion of resistance training components. There has also been a marked rise in implementation science within physical activity research, focusing not only on efficacy but on scalability, system integration, and real-world translation into primary and secondary care pathways. Longer-term follow-up has been more common, with several contemporary trials and cohort extensions reporting outcomes beyond 2 to 5 years, addressing earlier concerns that exercise research relied too heavily on short-duration endpoints. That said, important gaps remain. Head-to-head comparative trials between structured exercise prescriptions and procedural or invasive interventions are still relatively uncommon outside selected cardiology and oncology contexts. While funding streams and international collaborations in exercise, oncology, and cardiometabolic health are expanding, coordinated multi-site interdisciplinary exercise medicine research remains underdeveloped compared with pharmaceutical research infrastructures. Conclusion. Exercise medicine research is more rigorous and implementation focused than it was in 2014. However, comparative trials and large-scale coordinated funding still trail behind other treatment areas. The evidence is stronger, but system-level integration remains incomplete. Final reflections. Looking back from 2026, many of Anne Gates' perspectives from 2014 not only stood the test of time, but anticipated future developments in clinical practice, research and health system design. Exercise medicine is now more embedded in routine care, brief interventions are backed by behavioural science, and equity has become a central concern. We asked Anne for thoughts on re-listening to the podcast. Revisiting that 2014 conversation on the Physio Matters podcast, I'm struck by how consistent the core message remains. Movement is powerful medicine. The evidence base has only strengthened over the past decade. What has evolved is our understanding of implementation and scale. Brief advice is well evidenced, and approaches such as make every contact count have rightly embedded physical activity within routine care, but advice achieves its greatest impact when the system around it supports and sustains behaviour change. Professional education, service design, leadership priorities, and community environments determine whether movement becomes normalised or remains dependent on individual advocacy. The next critical step is strengthening our collective change agency. Redesigning healthcare so prevention is structurally embedded, aligned with the systems approach set out in the World Health Organization's Global Action Plan on Physical Activity. Movement should be a mainstay in prevention, treatment, and rehabilitation of ill health across the life course. The science is clear. The responsibility now is collective. Our collective responsibility is clear. The vision of universally integrating exercise into every consultation, ensuring consistent access to supportive community resources, and developing robust comparative evidence remains a work in progress. The conversation Anne started over a decade ago continues to shape how clinicians view physical activity, not as an optional extra, but as a medicine with profound, evidence-based impact.